We will now move to the last speaker, Sonia Luque, who is a clinical pharmacist working at the Hospital del Mar and a researcher at the University of Barcelona. Her field of interest focuses on antimicrobial therapeutic drug monitoring, and she's also an expert in antimicrobial PK/PD modeling in severe infections. And Sonia will share today her expertise and experience in Daptomycin and Linezolid TDM. So thank you, Sonia.
Thank you very much. Can you see my presentation?
Yes.
Okay, is everything right?
Yes.
Okay, thank you very much. So good morning, my name is Sonia Luque. I work at the Hospital del Mar, which is located in Barcelona. And I would like the organizer for inviting me to this very interesting workshop. And my presentation is going to be about therapeutic drug monitoring of Linezolid and Daptomycin. But before I start in my presentation, I would like to ask the audience one important question. If you had to choose between any of these two drugs, Daptomycin or Linezolid, for starting a TDM program in your hospital, which one would you choose? And I'm going to try to help you decide which is the best drug. And for this, I'm going to use this index. Firstly, we're going to briefly review the PK/PD properties of Linezolid and Daptomycin, and also which experiences have been published about these TDM programs. After that, we're going to try to know if any of these drugs fulfill the drug criteria of TDM. Third, we are going to look at the guidelines. And finally, I would like to share with you my own experience about TDM in our center. So let's go to talk about Linezolid. As you all know, Linezolid is a lipophilic drug, and it has a nonlinear PK profile. It is mainly cleared by a non-renal elimination, and what is most important is that it has demonstrated a significant intra- and interpatient PK variability. Regarding the PK/PD parameters, Linezolid has a concentration, but also a time-dependent antibacterial activity, and so different PK/PD targets have been suggested, but the time above the MIC is the most used. So different studies have demonstrated that this value should be between 80 and 100%. And that is the same that we have to look at the trough concentration that should be higher than the MIC during all the dosing interval. I think that we are also very lucky because we have an exposure toxicity cutoff point. That is that the trough concentration shouldn't be higher than 7 milligrams per liter. So we know now that we should measure the trough concentrations. And if we put together these 2 points, we are able to define a therapeutic range for Linezolid that should be a seeming concentration between 2 and 7 milligrams per liter. So one important thing to consider, to highlight, is that many studies have demonstrated that some special population can have alterations in their PK parameters of Linezolid, such as septic patients, critically ill patients, patients with kidney disease, patients with alterations in their body weight, so low body weight or obese patients, cirrhotic patients, within others. So maybe in these patients, TDM could be a useful tool or a necessity. And here I would like to show you some experiences that have been published about different TDM programs of Linezolid. So some of them are retrospective, but others are prospective. And as you can see, some of them included a high number of patients and also samples. And what is important to highlight is that about 40% of the trough concentration that were analyzed were not within the therapeutic range. And here, 3 more new experiences. being one retrospective and two prospective. And what is important is that some of them tried to associate the performance of a TD program of Linezolid with some clinical outcomes, such as the clinical cure, cost savings on prevention of toxicity. As you can see, the first two obtained positive results, but not the third one. In my opinion, we still need more systematic studies to confirm the potential clinical impact and the cost effectiveness of a TDM Linezolid program. Let's go to talk now a little bit about daptomycin. Daptomycin is an hydrophilic drug and it has a linear PK profile, even at very high doses. It's primarily excreted unchanged by the kidney, so the clearance will be affected or will be reduced in patients with renal impairment. And what is most important, that it has also a high inter-individual PK variability. Regarding the PK/PD, we know that it has a concentration-dependent bacterial killing, and also different PK/PD targets have been proposed, but being the AUC-MIC the most used, and a value of an AUC-MIC higher than 666 has been associated with a lower mortality in a clinical study. And this is that one that we are using in our clinical practice. We have also an exposure toxicity that is a trough concentration that should be lower than 24.3 milligrams per liter to try avoiding muscular toxicity. So here we know that it's important to measure trough and peak concentration so we could estimate the AUC. In the same way that with Linezolid, multiple studies have shown that some population can have altered PK of daptomycin, such as septic patients, patients with kidney disease, hospitalized patients with severe gram-positive infections, cancer patients, and others. So again, maybe TDM in these patients may be necessary. And here again, I would like to share with you the experiences that have evaluated TDM of daptomycin. We have to admit that there are, so that the evidence is much lower with daptomycin than with Linezolid. Here you can see 3 programs, and in all of them, the number of included patients were much lower, between 60 and 90. And it is important to highlight that a high proportion of the variability observed in the plasma concentrations could not be explained by the dose given or by any covariates. And here 3 more experiences, but there are only case reports that included just 1 or 2 patients in which TDM was used to guide the treatment. So again, and unfortunately, we have to admit that we need future prospective new studies to assess if this strategy may have a potential clinical impact on our patients. So now, up to this point, I think we're able to try to know if daptomycin or Linezolid fulfill the criteria for TDM. And so in this slide, on the left side, you can see the different criteria that we can use for selecting a drug. And let's go what happens with Linezolid. We have said that it has high PK variability. We have also exposure toxicity and efficacy range. We know that we should monitor the trough concentration. Different validated analytical methods and ISO Bayesian programs for dosage individualization are available. But in my opinion, we need still more information about clinical benefit and cost effectiveness. And what happens with daptomycin? We have also shown that it has a high and important PK variability in special population. We know also that we need to achieve an exposure range, an AUC-MIC, and also we have a toxicity point. We know that we should measure trough and peak concentration. We also have different validated methods by HPLC. We know there are some Bayesian programs, but the evidence is much, much lower. So maybe we need more information before we can make a decision. So let's go to look at the guidelines. What is recommended in the guidelines? So unfortunately, we don't have many guidelines, but we have this practical guide that I think that it has already been presented. And this position paper will help us to decide how antimicrobial TDM can be applied in our hospitals. Let's go what the authors say. So the panel of experts, in the case of Linezolid, they recommend that TDM should be performed. They also suggest that the trough concentration should be measured, and also they propose a therapeutic range between 2 and 7 milligrams per liter. But on the contrary, about daptomycin, the panel neither recommend nor discourage TDM of this drug. So now I think you are ready, and we are ready. Time for voting. I don't know if you have changed your initial opinion. Sorry. So which of these two drugs would you choose? So in my case, I think the winner is Linezolid. And for the reason, Linezolid was one of the first drugs that we included in our TDM program. So now I would like to present you some data of our TDM program that was started in our institution in 2010. And to date, it has been implemented in 3 different hospitals in Barcelona. So we perform proactive TDM and also some research studies. So in this slide, you can see the list of antimicrobials and antifungals that are that to date we have included in our TDM program. And as you can see, both Linezolid and Daptomycin are part of it. And here you can see some results, retrospective results for our from our TDM program of Linezolid, that it was started about 9 years ago. And to date, we have included almost or more than 700 patients with a median age of 70 years old. And as you can see here on the right, so the majority of them, well, more than 50% of them were critically ill, but we have also obese patients, underweight, or patients with renal impairment. Looking at the treatment data and PK/PD data, you can see that more than 95% of our patients received the fixed standard dose of 600 milligrams every 12 hours. That in almost all of them, as the trough concentrations were measured, and also in more than 25% of our patients, more than one concentration was obtained during treatment. And here you can see the median PK Linezolid data, so the trough concentration and the AUC. And on the graph, you can see that in only 34% of our patients, the trough concentrations of Linezolid were in the therapeutic range. In 36% of them, it would be considered suboptimal or infratherapeutic, and in 30% of them, they could be potentially toxic. In addition, I would like to highlight that in about 200 patients, the concentrations were very, very low or very, very high. And here, let's go to show you the results of our TDM program, that it was started just 5 years ago, 4 or 5 years ago. And we have only included 63 patients, also with a median age of 70 years old. Again, so the majority of them are AUC patients or patients from special populations. Here's some data about the daptomycin treatment and PK/PD. So as you can see, so the median dose was a very high dose. Almost all our patients, both the trough and the peak values were analyzed, and also in 19% of our patients, more than one sample could be obtained during the daptomycin treatment. And here you can see the median values of the peak and the trough and the AUC. And on the graph on the left side, you can see so the efficacy or the potential efficacy. So in more than 94% of our patients, and what is considered an optimal AUC MAC, so higher than 666 milligrams, could be achieved. But I would like to show you also that in 29% of our patients, here on the left side, trough concentrations were above the toxicity cutoff point of 24.3 milligrams per liter. And finally, before I finishing my presentation, I'm very happy to share with you some results, some studies that will be that I think that they will help us to better understand the use the TDM of Linezolid. So how to use TDM of Linezolid. Here is this population PK model of Linezolid that we did in collaboration with the University of Liverpool with the Professor William Hope. So the model included a high number of patients of our TD program, and the model will be including to test those. So I'm quite sure that it will help us to better dosify our patients. And also, we are starting this multi-center prospective PK study that, in 4 different Spanish hospitals, and with the final objective to assess the clinical impact of TDM of Linezolid in our patients. So just to summarize some key points, so the aim of TDM is now to optimize the PK/PD of many antimicrobials. So recently, the use of TDM has been extended to new drugs, such as could be Linezolid or Daptomycin. It seems that both drugs may be good candidates for TDM because they have a high PK variability and also defined exposure range. But evidence is still low, especially for Daptomycin, so we need more studies to confirm that. And finally, I think it could be very useful for us to have more practical guidelines on how TDM should be applied in our hospitals. So muchas gracias. Thank you very much. And I'm very happy to answer any of the questions from the audience.
Thank you, Sonia, for this very, very interesting talk. I have to start a question for you. It's not totally surprising to see that the one dose fits all doesn't work for Linezolid as well. But my question, you show that more than 30% of your patients experience toxic concentrations. Did you reduce the?
Yeah.
I assume they were receiving standard dosing, and did you reduce?
Exactly. So, yeah. So at the beginning, when we started the program, we just analyzed the samples because we were trying to learn about Linezolid, But after maybe I can't remember exactly, maybe in 2000, after 3 or 5 years, when we were more confident, so we decided to start reducing the doses because we observed that some patients had important hematologic toxicity, so thrombocytopenia, and that was quite important. So we in some cases we had even to stop the treatment and then to restart again with a dose of 600 milligrams every 24 hours instead of every 12 hours, every 24 hours. That's okay. What we usually do. I'm not sure if anyone has. So I don't know if it should be better to use this dose instead of using 300 milligrams every 12 hours. I think there isn't any published study about that, about these 2 potential dosage adjustments.
I don't think so. I'm looking at the attendees' questions. Do you adjust drug dosing for obese patients and extremely obese patients for Linezolid? You had some in your cohort, and did you use higher dosing regimen?
Yeah, so in all these patients from special populations, so in almost all of them, when it's possible, we perform TDM. And in obese patients, we have observed that some of them can have very low concentrations. So in some of them, we try to increase the dose to 600 milligrams every 8 hours. But we have also observed that it's so when you increase the dose, it's very important to perform a second TDM, because in some of them, we don't know exactly why. So the levels increase too much, and then we had to reduce again the dose. So if we increase the dose in these obese patients, it's very important, as we have observed, to perform to confirm the levels with a second sample extraction.
So do you think there's sort of accumulations or release?
Yeah, and also maybe the clearance could be reduced in obese patients. I think so.
So we have a remark from Jason Roberts regarding Linezolid dosing regimens, mentioning that probably the 300 milligram BD versus 600 milligram daily would be better in terms of in vitro pharmacodynamic.
Okay. Thank you, Jason.
And from Jan, a question: do you have a different strategy between Staphylococcus or Enterococcus for Linezolid or Daptomycin?
Do you mean for dosage adjustment?
No, for targets.
No.
Minimal targets, no.
Sorry?
For minimum targets, because we are using Linezolid more often these days for enterococcal infections. MRSA is not so frequent finding here anymore. So I'm always wondering, because we like to extrapolate the pharmacodynamic data, often based on Staphylococcus, we extend it to Enterococcus. We do the same for gram-negative versus gram-positive for some other drugs. And I always wonder how much evidence there is to just blindly do this.
Yeah, I agree. I completely agree with you. I think so we don't have enough evidence to do that. So we do that, but it's true. And that's the same that it happens with the vancomycin, that the majority of the studies have been performed with Staphylococcus and not with Enterococcus. And we also assume an AUC MAC of between 400 and 600. So yeah, I think we should do studies focused on different microorganisms, just to know if we can use the same PK/PD targets. It is a very important question.
Another question is about N-bound Daptomycin TDM. If there's any evidence for that, given its high protein binding? Is it technically difficult, or?
Yeah, I know. This is also
target to define the target.
I know. So we are using a total PK/PD targets, and we are just measuring the total concentrations. So we tried to measure the unbound concentrations by ultrafiltration, but it has been difficult, and also it increases your costs. And I'm not sure if there is any study that have evaluated free PK/PD targets for Daptomycin, so I'm not sure. But I think that maybe we are doing some mistakes, because as you all know, some special populations can have a reduced protein binding, so that could help. That could affect for sure the PK/PD target. So I think this is an important limitation that we have to assume that we are doing.
Okay, thank you, Sonia.
Thank you
for these answers and for this excellent talk again. So I would like now to thank all the speakers for this amazing webinar with lots of interactive debates, and I hope you all enjoy it, and that this webinar provides you insightful thoughts and experience with TDM, and that can help to implement this approach at bedside. I would like to thank the Thierry Reduce for co-organizing this event, and also to remind you that all the presentations are recorded and will be available soon on the Thierry Reduce website. So don't hesitate to share this information around you. And again, thanks to all the speakers. I know it's a quite busy time for all of you, and it was a great pleasure to have you today for this webinar. Thank you very much. And I don't know, Jason, if you want to add something before closing this webinar?
I think I would just say that that was expertly chaired. Claire and the speakers were all fantastic. Some wonderful learnings, and I think it's very exciting that, although as Jan remarked earlier, that it's not as exciting as seeing each other together in the same city at a conference. It's wonderful that we can spend this time together exchanging ideas, and it's fantastic that our collaborations that we all have, and not just the speakers but also the participants, can continue to grow like it has. So it's a pleasure for us to be involved, and we're very grateful for all the support that we've received from all of you. And I'd like to give a special thanks to Luminita, Vlad, who's really managed a lot of today and the lead up to today, and I'm really grateful to the expert way she's done that and made this as professional as it possibly can be. So thanks very much to Luminita in particular.
My pleasure. Thank you.
Thank you,
Claire,
Jason. And thanks to all of you. I also thank Lubna for her help in organizing this webinar, and I wish you all a very pleasant day. Thank you, and bye.
Bye, everyone. Thanks again.
Bye-bye, everybody.
Bye, everyone. Thank you.
Good evening, good night, good morning, good afternoon, wherever you are. Bye-bye.
Bye.